Good morning, good afternoon, good evening, wherever you are. And we really do have people from across the world joining us. You're all very welcome. I'm Christine Hancock from C3 Collaborating for Health. C3 is a London-based NGO working globally to prevent ill health, particularly NCDs, chronic disease, and with a real focus on the main risk factors. Since we've started, we've been holding international seminars as we believe strongly that learning and hearing from different countries can stimulate ideas and help make progress in each of our countries. We used to have wonderful international breakfast seminars, which were famous for their healthy breakfasts, which we got up early to make. And several people here now have been at those breakfasts and enjoyed our breakfasts. But of course, since the beginning of the pandemic, we realized that we needed to go online, and those cozy meetings in London couldn't continue. And while in theory they could now, what we've of course realized is it's much easier to find our international speakers, as we don't have to wait for them to be wandering through London and grab hold of them, as we have many of you. But also we're able to reach a much wider audience. So we've not gone back to those friendly breakfasts, and we've really enjoyed being able to hear from and meet people from such a wide range of countries and backgrounds. The seminar is being recorded, and the recording will be available for people. Please use the chat column for questions and comments. And most of all, let's welcome Professor Srinath Reddy. Srinath, you have interested a higher number than we've, I think, ever had before on our online seminars. I'm sure it's partly you and partly your topic, which is what we're waiting to hear from now. And Srinath, I think, is known, respected, and indeed loved around the world for his work with the Public Health Foundation of India. India is such a large and important country in this battle against ill health and chronic disease and unnecessary premature mortality. But Srinath also has a major career at Harvard and is known and respected globally for the work he's been doing. So I think your topic of really making the NCD world, many of whom are here today, really challenge why more isn't happening. So Srinath, over to you. We're looking forward to hearing from you. And I think that you'll leave some time for some discussion and comments at the end, but people, please put any questions or comments in the chat column. Welcome, Srinath, over to you.
Thank you very much, Christine. I had originally proposed that I'll speak something on implementation research, but I was wisely counseled to change the topic to why do we know so much, but do so little? Because that gives me an opportunity to give a talk which covers several aspects of NCDs, of which implementation would be one component and research would be an ancillary component of that. We must recognize that while we are substantially focused on NCDs with a great deal of concern and commitment, there are many other areas which are now engaging the world of global health, from primary healthcare-led universal health coverage, social determinants of health, climate change, nutrition security, zoonotic diseases, with a pandemic yet to be over and more possibly to come, and the exciting world of digital health, which carries a lot of hope and some hype, where do NCDs stand in this? I believe NCDs are very important in each of these areas as well, and we must find effective methods of integrating ourselves into that, of entering the agenda of action in each of these areas and becoming part of the implementation pathway. But firstly, in terms of the path to NCD prevention and control, we must recognize that there are several steps, some of which have taken place, some of which are still evolving. It is firstly to define NCDs, then defining the targets, identifying the interventions, undertaking effective implementation, and tracking progress. Do we have consensus on each of these? Not necessarily so. We started off in 2011 with a statement that we are addressing 4 major NCDs: cardiovascular diseases, cancer, respiratory diseases, and diabetes mellitus, linked by 4 common risk factors: tobacco, unhealthy diet, physical inactivity, and alcohol. A good place to begin with. But then we recognized that mental health is a major challenge that we need to integrate into the world of NCDs, and air pollution is becoming an increasing threat as a risk factor for a variety of NCDs, apart from other health conditions. And therefore, that was brought into the risk factor mix, and 4x4 became 5x5. But then came the question of liver diseases like cirrhosis, non-alcoholic fatty liver disease, kidney disease, oral health, eye health, and many other conditions, which said, aren't we NCDs too? Where are we in this agenda? But we did move from 4x4 to 5x5, but we did set a mortality target as we did so. From 25 by 25 in 2011 to a third by 30 in the UN SDGs of reduction in premature mortality in the age group of 30 to 70 years. But then these came under some challenge because people posed the questions, and rightly so, where is the question of equity here? What about NCD conditions and even deaths under the age of 30 years or over 70 years? Why are we ageist? What about childhood cancers, for example? Now, the question also came up, why are we not considering morbidity measures, especially mental health? In order to understand whether these targets are appropriate or not, we must understand the dynamics of health transition. Countries in early transition will see during the period 2011 to 2025 or 2015 to 2030, NCD mortality move mostly into the middle age, Africa, for example. Countries in mid-transition, like India, for example, NCD mortality will be split between middle and older ages. Countries in late transition, like Europe and the United States, will see NCD mortality remain mostly in the older age group. Therefore, the 30 to 70 mortality target doesn't fit all. It is good for exhortation, for action, but for accountability, it is not necessarily a fair indicator when it comes to covering all countries. In terms of alternatives, the idea of premature avertible mortality from NCDs was proposed by Lloyd Sherlock, Solis and Vega, and others, a Lancet publication of 2020, who suggests that all NCD mortality causes that are preventable through public policies and health programs or are amenable to health care should be included under this bracket with a calculation of years of life lost due to premature mortality. And now they've also reported that premature avertible mortality due to NCDs declined by 1 to 3% per year from 1990 to 2017, but absolute number of avertible NCD deaths increased by 49.3%. Only high-income countries are currently on track to SDG 3.4 was their observation. And high premature avoidable mortality clusters in low and middle income countries, and this is only to be expected. But it also means that the agenda of action has to be much more urgent and much more impactful in the low and middle income countries. The questions, of course, that are often raised and that we need to really look at this when we address the meandering path of NCD prevention and control globally is, why is it a priority? This question was asked, for example, before the Millennium Development Goals were framed in year 2000. Economists from the World Bank published in 1999 that NCDs are not a problem of the poor in the low and middle income countries. And indeed, any allocation of resources for NCDs would be anti-poor because it would divert resources from communicable diseases and maternal and child conditions, which are the major problems of the poor. It was that logic that influenced the MDGs as they were being framed, and NCDs, including tobacco control, were completely left out. I did protest in a letter to Lancet, and Richard Horton wrote an editorial in the Lancet supporting my contention that this was a false argument, but nevertheless, MDGs ignored NCDs. Acknowledgement was, however, not too late in coming. It came in 2011 after the World Bank changed its own position in 2007. And in the UN high-level meeting in 2011, we had a clear-cut consensus among the global leadership as a political declaration that NCDs are indeed a problem. But even there, interesting debates took place. There were people who opposed the word an epidemic of non-communicable diseases, because an epidemic meant that patent rights would have to be relaxed under the Doha Declaration. People opposed it as a threat to development because development partners, international aid agencies, felt that they would be asked to give money for NCD prevention and control. Nevertheless, the political lip service that was paid in the UNHLM did set a fairly good agenda and opened the pathway for NCD action. Now, the goals and targets were set in 2015, which were much more unequivocal. As far as the global burden of NCDs is concerned, there is no challenge. 74% of the deaths worldwide are due to NCDs, and 77% of these occur in low and middle income countries. And as we know, when health transition takes place, the NCD burden shifts to the poor among countries and the poor within countries. And therefore, the argument that NCDs are mainly a problem of the rich is dead and buried. 86% of the NCD deaths in the age group of 30 to 69 years occur in the low and middle income countries. And that is a huge loss of productive person power in the midlife. Now, cardiovascular diseases are the leading causes of NCD mortality, followed by cancers, respiratory diseases, and diabetes. And this is fairly well known to the group that is assembled today. But it is interesting that even in 1990, when the global burden of disease study started and published a few years later, NCDs had indeed globally outranked communicable diseases, and their burden grew by 2010, grew by further by 2015, and has continued to grow. But the recognition was considerably delayed for a variety of reasons, because many of the rich countries were unwilling to spend resources on this through their development agencies, and that influenced also the global agenda at other levels. And national governments felt that they had enough on their hands with maternal health and child health and infectious diseases and could not really allocate their scarce resources for this. Now, the argument is clearly made that not only are we responding to NCDs as a threat to human health, as a moral obligation, but also as an economic imperative, because we recognize from the Harvard and World Economic Forum study of 2011, which indeed influenced the political meeting in New York, the UN high-level meeting, that $47 trillion would be lost to NCDs and mental health between 2011 and 2030. And also subsequent publications between 2010 and 2025, the deaths from 4 main NCDs will rise from 28.3 million to 38.8 million. And of the 10.5 million additional deaths, 9.5 million would be in the low and middle income countries. So the theater of action would have to be very much in the low and middle income countries. But there is also, while there is a price to be paid for inaction, there is also a prize of action. It was modeled that 37 million lives will be saved if we act on 6 risk factors. And if NCD 25 by 25 targets are nearly achieved, and the gains will be even greater if tobacco use prevalence is reduced by 50% instead of 30%, which was the modest goal in the SDGs. And gains would be even further greater if effective primary and secondary prevention is extended through clinical care of high-risk persons, that is coverage through essential medicines. So there was a clear sense of optimism that if only we would act and implement, there is much to be gained. However, the NCD gap assessment in 2020 in the midpoint evaluation reported that other than tobacco control, little progress is seen in other risk factors. Inclusion of mental health into the 5x5 agenda has not fostered connectivity in implementation. It's good, politically accommodated, but operationally not connected. The WHO's work across risk factors is siloed, and WHO lacks resources. Nothing of this is really new, but the fact that the agenda of global action, which was well set in 2015, did not really bring about a change was dispiriting. Now, what needs to be done? Very clearly, now there is a further expansion of the intent to act. And the WHO Global Action Plan, which was prepared for 2013 to 2020, which has been extended to 2013 to 30. There is a global NCD compact that has been assembled of various partners to act in order to bring about better global NCD prevention and control. And there is an implementation roadmap for 2023 to 30. And there have been many people like Robert Buglehole here who have been leading the effort to really put greater energy behind the intent. Is it being done effectively or equitably? So we know what needs to be done, but the question is it being done effectively and equitably? It has also been pointed out that research has been the weakest NCD gap objective in terms of implementation, and progress in implementation research has been slow and incremental. Not only implementation has been of a lower magnitude than we wanted or hoped for, but the knowledge creation that was required for infusing greater energy into the action and for appropriately assessing the progress has not really happened to the extent it should have. Now we know that the world is experiencing health transition at a faster pace than in the 19th century or the 20th century. We have low-risk populations that are being propelled into high risk because of a combination of demographic and social determinants, and we need public health interventions in order to slow down the process and possibly reverse that. We know that within each population, there are low-risk individuals who are being moved to high risk because of a combination of biology, beliefs, and behaviors, and we need a combination of clinical and behavioral interventions in order to counter that. The agenda, therefore, is quite widely encompassing in terms of strengthening NCD surveillance of disease burden, risk factors, multi-sectoral action for prevention, which will involve enhancement of health and nutrition literacy among the population, and macro policies which help to stimulate behaviors which are conducive to making and maintaining healthy choices across the life course of individuals. And there are NCD-related health services which will involve a multi-layered, multi-skilled health workforce, availability of drugs at affordable prices, and technologies which are appropriate. But we also need the positioning of NCDs in UHC at all levels of care, primary, secondary, and tertiary, though primary would be the most pivotal, but we need chronic, comprehensive, connected care. But we also need a life course approach. We can't focus only on 30 to 70. That would be counterproductive. We know that NCDs have their spectrum of risk across the life course. And there is acquisition of risk, where the newborn inherits risk through genetic and epigenetic mechanisms. The child has early exposure to risk. The adolescent starts experimentation with risk behaviors. There is augmentation of risk in the young adult with continuation of the risk behaviors and neglect of biological risk factors. And there is manifestation of risk in the adult with cardiovascular events, with death or disability, and in older adults, recurrent events and deaths. Therefore, the umbrella of protection through our interventions must also must cover the entire life course. In terms of the fetus, we must have assured nutrition in utero so that there are no epigenetic mechanisms setting the course for future cardiometabolic disease. In the childhood, we must ensure health promotion addressed both to the child as well as the parents. In adolescent, we need health promotion, particularly through peer-led programs. Among adults, we need to continue health promotion, whether they are community-based or settings-based at work sites and community settings. And in terms of risk detection and risk reduction, we need definite program interventions, plus clinical care and rehabilitation. In the elderly, all of the above, plus a variety of supportive services for rehabilitation and palliation. Now, we do know that among all of these, the World Heart Federation too has been fairly active. And during the period of my presidency, and supported later by Salim Yusuf, we launched 3 roadmaps. Clearly, at that time, the feeling was that if we are heading towards 2025 or 2030, and we want a fairly early and definitive impact on mortality, which was the target that was set, then we needed interventions which will have effect in a relatively short time frame. So tobacco control, hypertension control, and secondary prevention were prioritized as having large impact if implemented effectively. And the diabetes, of course, clusters well with hypertension control. Polypills are likely to assist health system to achieve better levels, and there is more evidence coming in, but uptake is limited, and we'll have to see why that is so and try and remedy that appropriately. In terms of healthy diets, physical activity, air pollution, they pose challenges of multi-sectoral implementation and countering by commercial interests, and therefore progress has been fairly slow, despite the rising threat of obesity across the life course from childhood obesity to adult obesity. We find that there has not been much action on healthy diets and physical activity. Indeed, in terms of primary care, there is much that can be done in terms of initial primary prevention through better education of people for self-referral and for professionals for opportunistic screening, initially using a large number of non-laboratory measures, and then based on well-developed and tested diagnostic algorithms which can be integrated into guidelines, we can have risk stratification and targeted screening for diabetes, dyslipidemia, and assessment of non-communicable diseases, and then further guidelines for management algorithms with appropriate therapeutic measures directed, whether they're pharmacological or non-pharmacological. But secondary prevention is likely to provide a great deal of returns on investment in the short time frame that we have in the lead up to 2030. There are a large number of people who have experienced a cardiovascular event, but are not adequately protected against recurrence or death. And we must certainly energize our efforts to give them the protection that they need. And this requires improving practice patterns of healthcare providers and integrating secondary prevention effectively into primary healthcare is absolutely needed. That we need enabling uptake and adherence by patients by improving availability, affordability, knowledge, motivation, support systems, simplifying the regimens, and strengthening health systems for chronic care, for better referral and follow-up, vascular and metabolic clinics, particularly in secondary care and possible in primary care, involvement of non-physician healthcare providers, and better monitoring and evaluation. We know that guidelines are developed with a great deal of hope that they will be adopted and applied, but then the whole process is a laborious process which starts with a debate among experts, further development, then dissemination to potential end users, and deliberation by various professional associations and agencies, and then finally acceptance, and then application in wider practice and feedback, which again provides a feedback into guidelines, and fresh evidence which is emerging also feeds into guidelines which are revised. But end users have engaged very late in the process, and therefore their uptake is often limited. Unless they become vital stakeholders in the earlier process of development, they are unlikely to uptake with a great deal of enthusiasm or understanding. And that is where we need to improve the whole process of guidelines development. Then, in terms of the gaps that exist in NCDs, in terms of the actual implementation, presently rates of awareness, treatment, and effective control are low in low and middle income countries. The health systems are not geared for chronic care, and costs of treatment are high, procedures and drugs. Health workforce is not adequately skilled for NCD and mental health care, and unregulated private sector often provides inappropriate care. Then we find that the health workforce is short in numbers, skills, and even in motivation in terms of dealing with NCDs. Healthcare services are tertiary care oriented. Neglect of primary care and chronic care is a special feature of low and middle income country health systems. As far as drugs and technologies are concerned, there's limited access and high cost. Health financing, NCD services are not adequately covered under universal health coverage. Integration among NCDs is splintered across various disease-specific programs, and integration with other health programs. Other health programs are segmented by age and fragmented by separate budgets, and therefore coordination is rather limited. We need to bridge all of these gaps and prepare a common agenda of action through consensual consultations. Now, coordination with other sectors, there's very minimal synergy and limited capacity for health impact assessment of policies and programs in other sectors. Will technologies enable us to quickly overcome health system challenges? Yes, if appropriately utilized. But as we are wisely reminded by Doug Engelbart, the capability infrastructure, which is developing very rapidly, requires the co-evolution of the tool system and the human system. How is our health workforce or our patient population well equipped at this point in time to absorb and appropriately utilize the technologies that are developing, and how are we helping them to do so? These are some of the implementation challenges that we must address. Now, in terms of cost optimization, because cost is often thrown at us as an important barrier, saying that all affairs of the heart are expensive, and that is not merely a poetic expression. That's a concern of budget makers. We know that cost can be contained by choosing effective interventions, integrating different NCD programs together, and by integrating NCD prevention and control into other health and development programs. And resources can be mobilized by taxing tobacco, alcohol, and unhealthy foods and luxury vehicles. And Philippines has done that and shown that. And there are other countries also who have been attempting that. Now, in terms of power of policy, we know that policy is absolutely critical because policy modifies social and economic determinants of behaviors. It influences how people eat, smoke, drink, and move. It creates enabling environments to initiate and maintain behavior change in communities and individuals, can impact on multiple risk factors simultaneously, multiple risk behaviors and risk factors, reduces population risk in a short time, is cost-effective, relatively easy to implement, provided there's political will, has intergenerational benefit, which is not usually quantified by economists. If you build healthy communities with tobacco-free spaces, with areas which are amenable to pleasurable and safe physical activity, establish food systems for healthy diets, that benefits not only the current generation, but benefits the future generations. And that is a benefit that is seldom costed, but an argument that we need to make. But when we come to policy, we realize that policy acts through programs and regulations. So how do we design them? Then how do we have the capacity for implementation of either programs or of regulations? Do we have the capacity for enforcement of regulations? And do we have the capacity for assessment of the impact? These are all areas which are gap areas that we need to bridge, even as we advocate for policy. But we must recognize that policy is not something that depends only on scientific evidence. Enlightened policy needs scientific credibility, evidence and rationale that comes from a confluence of biomedical, epidemiological, and clinical research. Financial feasibility, is it cost-effective? Is it affordable? Health economics research. Operational stability, is it steerable? Is it sustainable? Is it scalable? We need health systems or implementation research. And finally, political viability. Is the community ready and receptive? Who are the people likely to support? Who are the people likely to oppose? You need social science research. Unfortunately, we do not conduct this kind of confluent research, but still continue research in silos. And of course, we need multiple streams of data to give us this kind of integrated knowledge. And big data offers us an opportunity for that. But as Edna St. Vincent Millay says, upon this gifted age in this dark hour, rains from the sky a meteoric shower of facts. They lie unquestioned, uncombined. Wisdom enough to leach us of our ill is daily spun, but there exists no loom to weave it into fabric. So we do need to combine evidence from multiple sources and use our strengths in big data analysis in order to ensure that we can combine all of this knowledge into effective policy-making advocacy. Do we have an example of successfully advancing policy? Yes, tobacco control. Do we have an example of where policy is finding roadblocks? Yes, changing food systems to improve dietary practices. Let me start with the food and agricultural systems. What we need is to ensure that we have every person has affordable access to diversified diets that are calorically adequate and nutritionally appropriate at each stage of his or her life in a sustainable manner. But we know that what Harvard produces as the Harvard plate is very different from what the Food and Agricultural Organization says is the agricultural produce globally. There is a total mismatch between that figure and this figure. We also know that when we are talking about the food environment, we are talking about not only the food agricultural production, market and trade systems, food transformation, consumer demand, consumer purchasing power, and many of these areas that are influencing food supply, food marketing, food transformation, and retail and food demand, and ultimately translating into food choices. The industry throws at us the argument that people have free choice and that we should not have a nanny state which ought to be interfering with, which attempts to interfere with individual choices of people. And we'll have politicians who have a libertarian mindset who will also echo that. But we must recognize that choice is never totally independent. It is conscious, conditioned, and constrained. Conscious choices are made when a person is well-informed or ill-informed. Therefore, health and nutrition literacy have to be implemented much better by us. It will be conditioned by marketing and promotion, which is aggressive, and cultural factors. So we need to definitely ensure that we regulate unethical and aggressive marketing, which promotes unhealthy products like tobacco and unhealthy ultra-processed foods. But there are also constraints of economic unaffordability, of availability as well of affordability. So even if a person has the knowledge, the person may not be able to exercise their choice because of those constraining factors. So we have to really create social and economic conditions of production and supply, which ensure widespread availability at affordable prices so that the healthy choice becomes the natural choice. And for this, we need a combination. We need definitely to promote consumer consciousness. We need to veer industry practices by pointing out the health dividend and ensure that they produce healthier products rather than undermine health with unhealthy products. We need to frame national policies and framework through political, economic, and social motivators, and we need global agreements like for tobacco elsewhere too. When we combine all of these, we are likely to mold the markets in the manner that we want. But why did tobacco succeed? Tobacco control succeed where others are lagging behind. There are clear-cut factors. There was outrage at the effect of secondhand smoke on the non-smokers. A broad coalition was created as a public health movement and with well-defined asks: raise taxes, ban advertising, promotion, and sponsorship, ban smoking in public and workplaces, place effective health warning on product packs, promote tobacco cessation effects. Clear asks, articulated well, advocated strongly. And there was continued vigilance and monitoring of tobacco industry tactics as well as government response and public behavior. Social norms were reset, and it became a response at the level of the people. So which brings me to the community in my final summation. When we look at the scene that is actually being enacted in society, we deal with multiple actors who are involved: governments, implementing agencies, international organizations, academia, industry, judiciary, legislature, NGOs, media. All of them do not act with a common purpose. Not infrequently, they act at cross purposes. Each of these actors is complex in composition, and interactions among them are even more complex. We are really dealing with complex adaptive systems. However, the community can influence each one of these actors. The government, academia, industry, judiciary, they're not insensitive to the perceptions and priorities of the community. As the NGOs, the legislature, the media, all of them ultimately have to perceive and respect what the demand of the community is. Therefore, community must ensure that the responses not only must articulate them well, the demands for the policy and services, but also ensure that the responses are adequate to meet and appropriate to meet the demand. So for this, we must ensure that the community has opportunities to participate in participatory research, policy advocacy, program design, program delivery, and community-based monitoring. What we need is people-partnered public health and digitally enabled decentralized decision-making for effective implementation. We cannot have a top-down approach, either from the academia or from the government. We need to connect with the community. As Amartya Sen says, popular validation is the ultimate test. And that must have ultimately a translation into a demand which has community endorsement. And then only implementation will gather steam. And for this, we must also have good messaging, and I'm sure C3 does that very well. So when we message to policymakers or people, the messaging must be correct, clear, crisp, comprehensible, and consistent, and must be spread to multiple constituencies and through them to other constituencies. So this is an absolutely important element. So what do we need to do? We have a global action plan, a GAP, unfortunately termed. National Action Plan, NAP, again, rather soporific. But what we need is a rapid action plan, a RAP. Can we really hasten the speed of the song? Partnership will provide us the booster shots. And for partnerships, which will create synchrony of effort and synergy of effect by aligning interests and pooling resources, we must bring all vital stakeholders together. And therefore, there is an action almanac. We need to advance science, stream to social purpose, assemble an array of potential allies, adopt an agreed agenda, amplify advocacy, accelerate action, assert accountability, but all through never neglect the role of the community. Thank you very much. As Simone Weil says, attention is the rarest and purest form of generosity. Thank you for your gracious invitation and for your generous attention. Thank you.
Well, and thank you. I think attention has been at a very, very high level, Srinath. That was fantastic. I only have one question. I think people in the chat column, but I think others will come. But I have almost dozens. But so I suppose in terms of tobacco control, on one level, it's so straightforward, and that it's been so hard, whereas the food, nutrition world is, so, as you've drawn out, so complex. How would you sort of split your energy behind those two areas of risk factors? And then I want to ask you something about the community as well, because that's incredibly important.
I believe tobacco control is important, but it has some momentum behind it. It's absolutely important, and this is where we can have huge amount of gains. But I think there are opportunities being offered on the food and nutrition component by climate change. The threat of what climate change will do to agriculture, nutrition security is very real. Therefore, we need climate smart, climate responsive, and climate resilient agriculture and food systems. We need to really bring that. If you, for example, talk about millets, for example, 2023 is the year of the millets. Now, they're also much more climate resistant, much less demanding of water, and use every argument. I mean, tobacco is also an environmental threat. Tobacco consumes huge amount of water, huge amount of paper, deforestation. So we must recognize that there are opportunities in the agendas that are being articulated by others. And there are common causes, multiple common causes. In some, we will be the prime movers and others can be our supporters. In some, others will be the prime movers and we'll be the supporters. But unless we broaden the tent, we'll still continue to have our own flags flying. That's not helpful.
Agreed. I'm going to invite Jonathan Scher and then Robert Beaglehole and then Richard Smith to come off their mute and ask their questions. Jonathan's from an amazing organisation called the Queen's Nursing Institute in Scotland, where we at C3 have been doing some community engagement work with some highly skilled community nurses. But Jonathan, your questions about early health, conception, preconception. Please ask your question of Srinath.
Sure. As I wrote in the chat, it was a fascinating and very helpful presentation. I'm keen to share the recording with colleagues who will genuinely benefit from it. But although it was almost addressed several times during the presentation, I would be grateful to have the issue of the importance of preconception and interconception, health, education, and care addressed more explicitly, because that's a focus of what we're doing now with a program called Healthier Pregnancies, Better Lives. And we're trying to change the dynamic of when early really begins. And from our perspective, early is before pregnancy, whether the first or the subsequent one. But that wasn't an explicit part of this presentation, and I'm wondering whether that also makes sense to you, or if you have any advice on that front.
I would entirely agree with you. I mean, not just David Barker, but everybody else who's followed also with the epigenetic elucidation of the connections. We know that it actually starts with the girl child, with her nutrition, the size of the pelvis, which determines the placental blood flow to the child, nutrition during pregnancy, nutrition in early infancy. These are all important. So we must ensure that when we talk about food and nutrition or maternal and child health as being separate elements, we are actually committing a major error. So we really ought to bring in all of these elements. Air pollution, for example, exposure to air pollution during pregnancy can again result in a small child who is epigenetically malprogrammed. So I think the importance of nutrition as well as other environmental exposures in the preconception stage, during pregnancy and early childhood are a very important agenda, and they will win us many other constituencies. So as I said, this difference between maternal and child health, infectious diseases, non-communicable diseases is extremely artificial, and we ought to bridge those differences. And I fully agree that every opportunity we have to emphasize the commonalities, we should utilize them.
Thank you. Question from Robert, I think more than a question, from Robert Beaglehole, one of our previous speakers in the days when we provided real breakfast. Robert, it's not your breakfast time, I realize. Over to you, followed by Richard Smith.
Srinath, a brilliant, eloquent presentation as usual, and I'm grateful I stayed up late to hear it. I'm going to take a contrary position. I want to come back to your title, which was along the lines, why, if we know so much, do we do so little? Something like that. And paradoxically, Srinath, I think the problem is we know too much. If we knew less, and if we focused on 2 or 3 or 4 priorities, I think we would have a better chance of making progress. And I take you back to a 2011 Lancet paper, which you co-authored on priorities for NCD. And here I want to be a bit extravagant. I think we should do only one thing in the immediate future. I think we should get tobacco under control. And I say that because despite all that we're doing, there are more people smoking cigarettes around the world today. Oh, there are as many as there were 20 years ago, over 1 billion. And the great beauty of tobacco control now is we have the opportunities to reduce the harm from tobacco by encouraging people to transition to reduced harm products. Perhaps that's a little controversial for this hour of the morning or the night, but I put that to you, Srinath. Thank you again.
Thanks, Robert.
I'm totally one with you on the need to really pursue tobacco control with greater vigor and commitment across the board. On the harm reduction aspect, we beg to differ. India has actually banned vaping, and we are recognizing the dangers of vaping, hiding as a harm reduction product, influencing the behavior of multiple young adolescents in the United States and Europe. And we are seeing some of those effects, but that's a debate we can have. But tobacco overall certainly needs to be fought with great vigor, and we must use every opportunity. But I believe that we cannot completely disconnect with other elements of the NCD prevention and control agenda. We must try our opportunity everywhere. See, tobacco control comes even in secondary prevention of cardiovascular disease, and we should do that. Primary prevention, of course. But when we are really talking about tobacco, we also ought to be talking about diets, for example, promotion of healthy diets and physical activity. A large number of women in India don't smoke. They do chew tobacco, and we need to get them to give it up. But there are a number of people who also need to be protected from hypertension, for example. So I think we cannot have a single agenda. You might say that that is going to be an agenda which requires a far greater commitment and focus than currently. But I would still say that we need to deal with a little broader agenda of action so that we act on multiple risks, behaviors, and factors, and bring in a broader coalition.
So that leads well into Richard Smith's question, which will be followed by Obanolo from Botswana. Richard, your question.
Right. Well, actually, I've got 3 questions, which is maybe abusing my position. So these days, Srinath, I work mainly on climate change, and that's such a serious and such an existential threat. So, I mean, I think it argues against what Robert is just saying of concentrating just on tobacco, but I wonder how you think it affects the whole NCD program and NCD research. Secondly, I was rather embarrassed when I moved from the NCD world into the climate change world, how little I'd thought about air pollution, which is killing, 7-9 million people a year. Why have we done so badly with that? I mean, if you go to a doctor with a respiratory problem, he or she will always ask you about smoking, but they will virtually never, ever mention air pollution. Why have we done so badly with that? And finally, last week I had lunch with Nick Wald, and next year will be the 20th anniversary of his article on the poly pill. And do you not think that if we had followed his advice of making the poly pill much more widely available to people at 55 without any need for medical intervention, we would actually be in a much better position now than we actually are?
Wow, they're 3 very different, challenging questions.
I'll try and be brief, but thanks for these questions, Richard. Climate change is absolutely important. In multiple ways, it's going to affect NCDs and mental health. You're going to have severe heat effects, water shortage, water scarcity, and much more importantly, food security challenges. You're going to have serious challenges in which are going to be increasing the threat of nutritionally mediated chronic diseases, and heat effects, and particularly strokes are going to increase. Mental health has been shown to be significantly affected, and you'll have more of intergroup and intragroup conflicts. There are many, and of course, cancers. So there are very many ways in which climate change is going to affect, but nutrition security is going to be one of the most important elements that's going to be compromised. And we ought to really talk about it in the context of NCDs as well, not just in terms of more zoonotic pandemics or other problems that are associated. But that gives us an opportunity to talk about NCDs in that context. Air pollution is very critical and underlies many NCDs. I think one of the reasons why people have not really acted upon it is because of the addiction to fossil fuels. Again, of automobile industry has been a very persuasive campaigner for greater use of automobiles and fossil fuels. And in rapid industrialization, delayed, but nevertheless rapid industrialization in low and middle income countries seems to provide a stepladder to faster development, and they are loath to give up fossil fuels. But we ought to really deal with multiple sources of air pollution and then recognize that the biggest victims are going to be the low and middle income countries. And that's the point we are making, that no point in just blaming others. True, others are to blame, but we are going to be the biggest victims if we don't collectively act together. But I think it's a very important element that we ought to be tackling. And I think belatedly, the World Health Organization is also doing something about it. But more than that, we ought to be doing it collectively. And if you're campaigning for climate change response, I'll be very happy to be one of your foot soldiers. Now, in terms of the polypill, clearly, I think one of the reasons why it had a pushback when World came up with that was that it had 6 drugs, out of which 2 have fallen into somewhat of a disrepute at the moment, folic acid, as well as now even aspirin has come under some challenge now as a primary prevention agent. And whether there ought to be different polypills for stroke prevention and for coronary prevention is a bit of a finer debate based on the trial evidence alone. But I think there is increasing consensus that is being built up now with the recent evidence that we ought to be looking at it. But the initial response also was negative because you said, look, why are you not addressing other risk factors? Why are you not getting people to give up tobacco and smoking instead of just putting them on a polypill? Why are you not asking people to change their diets? I think we fell into the trap of either or. Both can be done. There's no reason why people can't give up tobacco and get their blood pressure under control with a pill. So I think we ought to really bring that both the worlds together now.
And the very last question, because we are running out of time, although I guess we could go on for a long while. So Obanolo from Botswana is working with us at C3 on work on oral health, which I have to say I'm embarrassed at how recently I've thought seriously about oral health and how it addresses so many of the issues. It doesn't have to be a new siloed thing, but that's not really your question. Obanolo, you're welcome. Over to you for the question.
Thank you, Christine, and thank you, Prof. Reddy, for the presentation. I have just 2 questions and 1 comment. I've heard you, I'm from Botswana in Southern Africa. I belong to the bracket of the low income to middle income. And you said about 32, the age bracket of 30 to 69 years, they're affected up to 86% death due to NCDs. But my question or comment will be, this is an age bracket mostly of youth who are now more on using data or cell phones as a way of communication. Don't you think it can be one line of bringing education? Because the theme of this is, why do we know so much, yet we do so little? Second one, I think, is the myth of smoking. You talk about tobacco. There's this myth, maybe in Southern Africa, especially in this age bracket of, say, smoking reduces weight, especially among women. What is your comment on that? But the third one, like Christine was maybe saying, is in relation to what do we know so much, yet you do so little? I think the issue of education, especially in terms of community, because I'm a registered midwife working in the clinics next to the communities. And I believe we can address through education with a bottom-up approach, then we can defeat NCDs. Thank you, Prof.
Thank you, Obanolo. And Srinath, we're running out of time, so
Okay, I'll be brief. I think I caught the first 2 questions. And third, I'm not sure whether I caught it, but social media, cell phones, young people, I think we now have new tools for disseminating health messages, but also engaging people in discussions and advocacy. And we ought to use all these technologies effectively. We have seen both the positive and the negative effects of social media. We ought to try and insinuate ourselves rather than dismissing them as dangerous technologies, of ensuring that they're appropriately utilized to good effect. And young people can be very important change agents. And after all, they're the biggest stakeholders in whatever is going to happen, whether it's climate change or nutrition security. And in terms of smoking and weight, this is a classical argument that is given, but it is true that in the initial stages of smoking cessation, people do gain weight. But if they actually take up physical activity and change their dietary habits, they don't need to gain weight, or they shed weight soon. So what should they have? Smoking plus ultra-processed foods and low physical activity as a combination for early death, or giving up smoking, taking healthier diets and taking up physical activity, controlling their weights in the appropriate manner rather than depending upon smoking. And because smoking is a huge cause of inflammation, inflammation may not result in overt obesity, but it is actually stimulating the adipose tissue to become much more inflamed. And that is the danger of obesity in terms of the cardiometabolic effects as well. So even without appearing to have an increased waistline, you're still suffering all the effects of obesity if you're a smoker. Then in terms of the bottom-up approach, yes, entirely. We do require policies to come up, but we also need the community to really articulate, because policies will not have an uptake or effective implementation if the community is not cooperative or unwilling to accept them. And secondly, policies will not get initiated unless there is a strong voice from the community demanding them. So it is absolutely important that the community be engaged and speak up. We need both bottom-up and top-down to be combined appropriately as the occasion demands.
Srinath, thank you for your time and generosity, and for such a fascinating, really interesting session. Really very helpful, I think, for many people, even those long in the tooth in the NCD world. I think you've given us so much, and you've given it in such a clear way to articulate these challenges. Your presentation, you've kindly said, will be available for people, so people can see it again and share it with colleagues. Please, everybody join C3's network, and then you'll know about our next international seminars, which of course will not be until next year. But Srinath, a very big thank you to you, and good health, and a good new year to you and to all our friends who've joined us this morning. Thank you all very much indeed.
Thank you very much. Merry Christmas and other parts of the holiday season, as well as a wonderful new year to everybody. Thank you.
Thank you.